First of all, I want to thank Dr. Said, Dr. Matthew, and I'm a young budding cardiologist in front of all you seniors. And with my limited experience in rotablation, I want to share two of my cases, which I thought I might stuck up in complications. I normally do rota, but normally we avoid rota as a usual teaching that in tortuous arteries, unless and until it is deemed required, you should avoid doing rota in these arteries. So how to handle rota in these tortuous arteries? This is, I'm going to present my case today. So this first patient is an 87-year-old female, hypertensive. She was an ex-smoker and she was admitted at our hospital with inferior wall MI, and PTCA2, RCA and LED was done. And now again, in 2020, she presented to us with pain, chest pain at rest for 4 to 5 hours duration. Her ECG showed STT changes, troponin was positive. So first I'm sharing the angiogram of 2015. As we can see, there is a borderline lesion in LCX with a calcified lesion in LED, which was fixed at that time. And that time, because we did not have that much experience with rota, we avoided distal RCA. We tried with a non-compliant balloon, but we could only put stent in the mid RCA, and distal RCA was left like that. Patient was fine for 4 to 5 years, but again, she has come to us. And now as we can see that there is some ISR with a tortuous calcified lesion and some lesion is in PLV. So in these type of arteries, when you need, there is a tortuosity at the calcium side and there's a distal lesion where you have to do rotablation. So this might be tricky in your, the case might be tricky and you might land in complications. So first of all, to have a good support, because you have to go distally, we chose an AL1 guiding catheter and this AL1, and we first wired this with a workhorse wire, and then with micro catheter, this workhorse wire was then exchanged to a floppy rota wire. And we kept TPI in the IVC, we did not put into the RV, so that if there is a bradycardia, we can just place it in the RV to get a support. So this is a normal wire, and then this is being exchanged with a rota floppy wire. And then with the Dynaglide mode, we actually bring that rota bar to the mid RCA site. And then to my surprise, there was a jump when I did a rota. As you can see that in this first view, we can see that there was a jump, and then we decided to rota with a 1.5 bar. We had a speed, the bar was at a speed of 165,000 RPM, and we did actually 6 to 8 passes. There was some, the burr was getting stuck at the distal side where the tortuosity was, but after 4 to 5, here the burr was getting stuck, but after 4 to 6 passes, when there was no resistance, we actually took this burr out, and then this was again exchanged with a workhorse wire. And then we dilated it with a non-NC balloon with a 2.5 and 315 balloon, and in PLV distal 2.75 16 millimeter stent was deployed. And despite doing rota, we had actually had to use mother and child catheter to deliver the stent to the PLV, because it was too distal and we could not track the stent to that site. And then the distal RCA stent 3 into 28 DES was deployed with the help of Guidezilla catheter. And the post dilation was then done with a 3.5 15 millimeter balloon. And this is the final picture. So in this case, we could actually get good expansion of the stent. We did not do imaging to see how much expansion was there, but angiographically it looked well. And this is the case 2, and this was 85-year-old gentleman, 74-year-old gentleman who had diabetes with nephropathy. And he was a post-CABG patient with grafts to LAD and SVG2M, which was done in 2016. And now this time he presented to us with recurrent angina for past 3 days. On echo, ejection fraction was 40% with infero-posterior hypokinesia. And we did angio through transradial route, through left radial route. And this, we could see that there was a tortuous circ with a proximal calcified lesion, as we can make out. and LAD was 100% occluded. And there was a bend after this proximal lesion, and this is Lima graph, which was actually patent. And this is the SVG2-OM, which was actually having a critical stenosis. So this was the scenario that this graft was going to the OM, and actually we could see that this OM was actually being filled through the, so this is the OM to which this graft was actually anastomosed. And we could see that there was a mild disease. So now, because this was a dominant circ and there was a proximal lesion, I thought we should do rota to proximal circ, and we should implant a stent in the proximal artery, and that should take care of this OM also. So the plan of management, we wanted to do rotas. We took a 7F EBU catheter. Now the procedure was done through transfemoral route, and we had a TPI, and the procedure was to do an angioplasty after rota plaque modification with rota and NC balloon to dominant circ. So again, this is a tortuous lesion in the proximal circ, as we can see, the same. Normally, this is how we follow. We normally put a workhorse wire, and with the help of microcatheter, we exchange it to rota wire. And then the burring was done. There was a little resistance at the site where the tortuosity was, and with again the burr was moving at a speed of 160 to 165, and we did 4 to 5 passes of rotablation. So here the burr was actually getting stuck, but after 2-3 passes we could have the resistance actually gone. Sometimes in these big arteries, if you're choosing a burr of 1.5 millimeter, you might not have a good expansion because you might need a bigger burr. So as a strategy, what we do is then after doing this, on this rota wire only, we inflate a bigger NC balloon and then see whether it is expanding well or not. So this is which was done. We had used an NC balloon 2.7515, and then we could see that there was a good expansion of the balloon. So the burring is effective, and now we can proceed with the stent. So this is 338 Des in the LCX with a wire in the OM, as we knew that this is the major OM and we had to take care of that. And then the proximal stent was deployed from LM Ostia to LCX, overlapping with the previous stent, because there was a calcified plaque in the lesion in the proximal circ also. So this is the positioning of from Ostia to the previous stent, and the pot was done with a 4.58 millimeter NC balloon. And this is the final picture. So rotablation in diffusely calcified vessels and tortuous vessels, this is very high risk and it can be technically challenging. And to reduce, the main problem with tortuosity is that because of the wire bias, you might have a eccentric burring and there are chances of having perforation. So complications are more in these arteries in form of perforations. So to reduce the risk of unexpected vascular damage by wire bias, sometimes these mother and child catheter, you can use this catheter and you can take your burr to the site of the lesion and then you can start burring. And then you are, most of the time, you are actually successful in doing rota in these arteries. And we know that there is a saying that you should avoid rota in these arteries, but sometimes plaque modification, you cannot track your shockwave balloon to these arteries sometimes. So rota actually becomes essential in these arteries. And as I have shown in my cases, despite doing rota and despite getting a good wire support, we actually had to use these mother and child catheter to help track our stent to the desired position. And this because both of these elderly patients, the first patient was 85, 86-year-old. And mind you, this patient was actually admitted, the first patient was actually admitted at some other center. And then they tried it without rota. But when they were unsuccessful, the patient was transferred to our center. And the attendants were really skeptical because of the age of the patient. So if you're doing the procedure and competently and you are taking care of everything, then you can actually safely perform rota in these very elderly patients. Thank you.
Thank you, Preeti. Before it's thrown open to the discussion, I just want two clarification from you. One, I heard you presenting that you on and off tried to get a high pressure balloon on the rotablator wire itself and try to inflate the balloon. The purpose is what?
Just to see, sometimes I stuck in, like in a 3.5 millimeter artery, if I have done burring with a 1.5 burr. Sometimes the burring is because either you should use imaging just to see whether you have produced cuts in the arteries, as this is classically said. And then you should actually try to track a stent across these lesions. But if simply you can see with a 2.5 or 3 millimeter balloon that the balloon is expanding well, then you can actually, if
the balloon is not expanding well, then what?
Then we have to use a higher bursar. Then in a 3.5, I will use a 1.75 burr.
I wanted you to commit that. That is one. Yes. Second is, I saw you using the pacing wire in the IVC. The purpose is that if a need arises, you can use that pacing wire for pacing.
Yes, sir. Yes.
I have two comments to make. One, pacing wire. In my experience, I've found using a pacing wire in the IVC becomes more difficult to handle than taking a new pacing wire right from the femoral vein and bring it up. Because this pacing wire generally becomes very soft, and when you really need it, the manipulation becomes technically very challenging. This is what I have felt. This is one. Number two is if you intend to use a balloon on the rotablator wire, there are two issues. One, there is a step up. When you take the balloon on a 0.9 wire, which is the rotablator wire, there is a step up on the balloon tip and the wire, which makes it more difficult for you to go down the vessel. Number two, if you get across and dilate, and if it is not dilating well, and then you try to bring in another burr using the same wire, there is a challenge because you don't realize whether the shaft of the wire is bent or not. We have had very early experience of shaft getting bent and burr cutting the wire off completely. And that is a dangerous thing to do. So I would suggest that you would avoid doing those two techniques and use devices the proper way.
So can I just comment, Preeti? That was some tremendous cases, and it's really encouraging to see that you're using devices, you're understanding them, you're gradually getting and more expert at it. And this is what is needed truly in our tier 2 cities, where you face these difficult challenges in very difficult circumstances and have the courage to be able to take this on and do very difficult cases. So congratulations, and keep this courage and truly enthusiasm up. What Dr. Matthews suggested is very correct. That's how you actually modify your techniques. That's how you learn your techniques. The other, just to complement what you're doing, firstly, I would always, you see, I never do a halfway stage. Like Dr. Matthews said, you either use it or you don't use it. You don't keep it in a situation where you actually, when you need it, you don't have it. You see what's going to happen? You can't get the wire in. It actually happens when you're burring. That's when the heart rate slows down. That's when it actually stops. That's when you say, oh my God, what's this? And then that's where you're rushing around. But it's always momentary. So either you actually give atropine prior to what you're doing, but I'd not even get into those circumstances. Doing difficult cases, just have it. Just keep using your balloon tip pacing wires to avoid complications, but just have it there if you're doing very complex cases. And if you're doing short lesions and simple lesions, then you don't need it. And you didn't need it at all in LADs on non-dominant circumflexes. So you just need it in large RCAs with long diffuse disease segments with a lot of intervention going on. So keep it there. Save your adrenaline for other things. That's the first step. And the second step is that the way we test out these is pass a second wire down. We never take our rotor wire out, and that's, I know most of the experienced rotor specialists do that. Put a second wire down, and then do your dilatations on your second wire. What that does is also uses the first wire as a cutting balloon in instances, and actually helps you to break those lesions far more efficiently. So when Matthew and I do it, I know we never take our first wire out. We just put a second wire down the side, and that's when we do the dilatations and then take our rotor wire out. It has double advantages. It's like a buddy wire. It also is like a cutting balloon, a poor man's cutting balloon, and it gives you expansion of the lesions rather than sometimes using a cutting balloon in stents. So those are the two important steps. And finally, I would say one, I mean, I saw maybe those were polishing runs, but I find younger individuals rushing with the burr. I mean, moving it too fast and moving that too forcefully. And when you see us do it, we maintain a gentle pressure for 3 or 4 seconds on the lesion, then come back, go back, and we gentle with the artery. We go across the bends very gently. We go across the region very gently. We don't rush out of the lesion. It's a very important thing to understand, that you treat the lesion gently, even though it's heavily calcified. And that's how we use rotational atherectomy. We never rush through a lesion, because that's what leads to entrapment. That's what leads to dissection. That's what leads to perforations.
And also, Ashok, use it only where it is needed. Don't pass the lesion, go far into the distal vessel. That is unnecessarily taking a burr where it is not needed to be avoided.
Well said. We see that so much. The burr swinging up and down the artery when the lesion was only 20 millimeters in between, and the burr swings for 50 millimeters across the vessel.
Just another comment. Excellent cases, Preeti. I really enjoyed you having, as Ashok said, the confidence to use rotor to avoid the context of rotor regret. We know that where the stent's not expanded because you didn't prepare the calcium. Just a comment about taking burrs through previously implanted stents, even chronically implanted stents. I've experienced problems myself, particularly if the lesion is distal and you're accessing through a proximal stent. There's the potential the wire can be under a strut, particularly in a very proximal right. I've done that myself, and I've fractured a wire at the ostium of a right, so be very mindful and be cognizant of to be under a strut. And the other thing is, if you're going through an old stent, and whether you're treating that with a rotor, make sure you image first, because it may be a mal-expanded stent, and that's an easy way to get a rotor burr entrapped. So not just cautionary tales about taking a burr. You took a 125 burr, then a 1.5 burr, no problems at all. But if you'd been under a strut, or if had been more tissue in there, or it's been mal-expanded, having been in those situations and put myself in those situations before, it's good to be aware of what could go wrong.
Thank you, Nikhil. That point has to be re-emphasized again, as he put it for, because you wouldn't realize 1 or 2 studs may be underexpanded, and the wire could have gone through that strut. And if you don't have imaging, you don't know where you are and whether the wire is through the strut or not. It's safer to.
This is why intravascular imaging is important.
Absolutely. A lovely session, Ashok. It was a nice session. Whole morning we enjoyed it. We learned it. Every day we learn something.
Absolutely, and I think when these presentations come from Sahu and Preeti, and in fact all of us, we always learning more and more. It's even Matthew. It's been so the history of rotational atherectomy goes to, I think, the Matthew first one to do rotational atherectomy in the country was Matthew. But and then when he'd done 10 cases, it was 92 that I went across to him when he'd done 10 cases, and I said, Matthew, this tool, and I was doing directional atherectomies, and Matthew was doing rotational atherectomies. 10 cases, I went across to Matthew in 92 and said, Matthew, let's watch you do this. And Matthew had 3 cases that day. He actually showed me how to do it, and of course, then I got back and started doing rotational atherectomies, and now. We are into 30 years of doing rotational atherectomy, man. It sounds weird that, and Nigel is a part of that, and Tegu's seen it all and been an integral part. When we actually talk about rotational atherectomy, for us, We were doing 150 cases a year and 200 cases a year as far back as 93 and 94. So you know, it's
That's
sometimes
right.
it
That's
seems
right.
the
And
whole.
so is Santoso. I mean,
Correct.
we
I
used-
remember that. and Nigel, all this is fascinating, isn't it? That we had no stents, and our mainstay of treatment, even for
Rotablation,
yes, non-calcified lesions, but long diffuse disease, tortuous anatomies, we were doing practically everything 28 years ago with rotational atherectomy.
In my practice, I just want to share that we have plenty of cases with chronic kidney disease, and nowadays we very often have to use this to apply the so-called zero contrast or ultra low contrast PCI. Very helpful.
Yeah.
Of course, with imaging,
Right.
IFOS and or OCT. With OCT, I normally use saline or gelofuscin, dextran, kind of.
We have one question to attend. We have 3 minutes to go. We have one question. I think we've done I think we've gone through the program. Is Dr. Mirwat on? Dr. Mirwat? So she had to leave in between. But we have one question out here. Nigel, I think you should be able to expand on that. Opinion of the panel regarding physiology in post-PCI well-expanded stent. You yourself mentioned about it, and can you just expand on that for the audience?
Yeah, no, thank you, Ashok. Look, most PCI is still globally is being performed angiographically driven. Obviously, we're talking today about the key role of imaging with complex disease with calcification. Defined PCI was a study done with confirmed physiologically abnormal, at least single vessel disease by the resting index, IFR. Then the vessel was treated according to standard angiographic criteria. A blinded IFR and an IFR pullback was performed at the end of an apparently successful PCI performed angiographically, and 25% of those cases had abnormal physiology following an apparently successful angiographic guided PCI. So this was not an IVA study, and there are issues, you know, with geographic miss, underexpansion, and the like. So I'm really, if we've taken the cost of a pressure wire up front to decide if we need to treat or not, I've changed my practice. If that wire is still very functional and the tip of it isn't too distorted, then I'll do a physiology at the end to confirm that I've corrected and normalized physiology. So that's the point there. I'm not saying it's in replacive imaging, MSA, not at all. It's just the principle.
Right.
May I share my experience with functional assessment post-PCI? So, for example, in the main vessel, normally I do this if we have tandem lesions. If they have tandem lesions, usually we have to treat the spot where we have the biggest delta, and then reassess the FFR or IFR after treating that lesion, and then I'll decide whether we need to address the other lesion as well. And of course, post-PCI IFR or FFR is also very useful to assess side branch. For example, left main, we after the procedure, we have pinched side branch, circ. Quite often, the lesion is not that functionally not significant, even though angiographically it looks significant. So this is what I do in my practice. But we know, as mentioned also by Dr. Jepson, in divine PCI, approximately, if I correctly, as mentioned, 24% or something has normal functional, even though on angiographically lesion looks fine. If we have this kind of lesion, of course, we have to define whether this is functional at the level of microvascular or distally, or anatomical. But usually the culprit is anatomical, so we have to look for unfavorable lesion or unsatisfactory result, like, for example, residual dissection, things like that.
Right. Matthew and Tegu, any other comments, or should we then close the session? Because we've answered a lot of questions. So if there are no comments, I think we've had a tremendous session. Thank you all for your contributions. Thank you all for your participation. And I think this was one of the most learning sessions we've had in recent times from the best experts around the world, actually, if I see around this screen on rotational atherectomy. Most experience and most with the maximum expertise. And I think we'll just have more of these. I think this has been a great education and an interaction. Even I've learned a few things as I've sat around these sessions. And with that, this APSIC partnership at SCAI is going to bring us more and better interactions and learning experiences over the year. Thank you for your participation. We'll call upon you once again in the future to be a part of these symposias. We thank Boston Scientific for supporting this educational activity. Thank you, Boston Scientific, for your commitment to education, teaching, and training. And then we really understand that you have some of the best devices which help our patients. So that's another aspect. With these words, have a good Sunday or whatever is left of it around the world. Some of us have some Sunday left. Others are practically completing their Sundays. But you've contributed tremendously to education. Thank you all for being with us. Bye-bye.
Thank you all.
Thank you.
Be safe, be well. Thank you.
Bye-bye.
Bye.